Okay, so today we will discuss the spine injuries, spine injury, general information, neurological assessment, whiplash, sports related injury, and pediatric spine injury. Page number 1118, Greenberg Neurosurgery. So, in introduction, the most important point two, we will just discuss the point two we remembered and discuss in detail for some topics which are important. So the most important here thing is कि there are only 20% of patient with major spine injury will have second spinal injury at another level. 20% patient, okay? Only 20% will have second spinal injury at another level. Second important thing is the arterial dissection has a direct association. A direct association. So only 2 points to remember in this introduction topic. Now comes terminology. What is spinal stability? Two definitions to be remembered here are, the first one is the White and Punjabi definition, and what is biomechanical stability. Now, according to White and Punjabi, the ability of spine under physiological limit to limit displacement so as to prevent, number one, injury or irritation of spinal cord nerve root, and to prevent incapacitating deformity or pain during structural changes. Okay, so one point, to prevent irritation and injury of spinal cord and nerve root, and second is prevent incapacitating deformity or pain due to structural change. What is biomechanical stability? Resist forces ex vivo, the out forces. Only two things to remember. Level of injury. So level of injury is, according to this paragraph, a level of injury is the level where the sensation or motor function is completely lost, or either at least 3 out of 5 is the power of motor. The level of spinal cord injury, lowest level of completely normal function. Okay, or at least 3 out of the 5 power is present above, but when it becomes less than 3 or less than 3 by 5, it is the level of injury. Now, completeness of injury, two topics important are the incomplete lesion and the complete lesion. First, we will discuss incomplete lesion. Whenever incomplete lesion comes into your mind, you should remember triple S. Triple S stands for sensation, sacral sparing, and sacral reflexes are preserved alone. Okay, so for incomplete lesion, triple S is important. Triple S means sensation is there, minimal or whatever is there, but not fully, but minimal sensation is present, or voluntary movement in lower extremities present. In sacral sparing, preserved sensation around the NS, voluntary rectus sphincter contraction or voluntary toe flexion is there. An injury is not qualified as incomplete with preserved sacral reflexes alone. If it is alone present, that it is not an incomplete injury. So this shows triple S importance. Okay, any residual motor or sensory function more than 3 segment below the level of injury, 3 segment is 3 vertebrae. So remember like this, greater than 3 vertebrae. Now the type of spinal cord injury. There are 4 types of spinal cord injuries. First is central cord syndrome, second is Brown-Séquard, anterior and posterior cord syndrome. We will discuss later. Now what is complete lesion? As we understood incomplete lesion with triple S, complete lesion is triple S AB, which is spinal shock should be absent. Okay, so वही more than 3 segment below the level of injury and no preservation and absence of spinal shock should be absent. Now if patient presents the important point is if patient presents within 24 hours of injury, then there is chances of 3% recovery. But if patient present beyond 72 hours, there is 0% recovery. The points to be remembered. We have completed our first page. I hope you got to know many things. Now the term comes spinal shock. What is spinal shock? The spinal shock is divided into two things. First is hypotension and second is neurological function. The first sense is the hypotension and the second is neurological function loss. The first sense is hypotension, second is transient loss of neurological function. So the important point here is there is hypotension is SBP is usually 80 mmHg, millimeter of mercury. There is interruption of sympathetics, injury above T1, the important point. This leads to loss of vasoconstrictor and vasodilatation occur. The first important point here. Secondly, bradycardia occur because of parasympathetic unopposed. Third is relative hypovolemia, which is due to loss of muscle tone, venous pooling. And fourth point to remember is true hypovolemia, which is due to actual blood loss. So hypotension starts. The two important points first you have to remember is that there is injury above level of T1 and second is interruption of sympathetics. Now interruption of sympathetics leads to parasympathetic unopposed. Interruption of sympathetic causes vasodilatation. Parasympathetic causes bradycardia. Loss of muscle tone, venous pooling causes relative hypovolemia and blood loss causes true hypovolemia. The 4 points to be remembered. Second is transient loss of neurological function. Here one important concept comes is Schiff-Sherrington phenomena, which we will discuss together. Now what happens is this leads to flaccid paralysis. Okay, includes segmental and polysynaptic reflex and autonomic function below the level of spinal cord injury and flaccid paralysis occur. Duration as late as 72 hours or 1 to 2 weeks or months, accompanied by loss of bulbocavernous reflex. Spinal cord reflex immediate above may be depressed on the basis of Schiff-Sherrington phenomena. This is important because Schiff-Sherrington phenomena states that spinal cord reflex immediately above the injury may be depressed, which when spinal shock resolves there will be spasticity below the level of lesion and return of bulbocavernous reflex, and this is a poor prognostic sign. Okay, so this is also important point. Schiff-Sherrington phenomena states that spinal cord reflex immediately above the injury may also be depressed, and as spinal shock resolves, when spinal shock will resolve, there will be spasticity below the level of lesion and reversal or return of bulbocavernous reflex. Okay. Now whiplash injury. The important point to understand here is it is a soft tissue injury. Okay. The most important point here is that it is a soft tissue injury and it is non-fatal in majority of the cases. So where does the injury occurs? Injury occurs in the cervical muscle, ligaments, intervertebral disc and facet joint. The highly important thing to remember is there is hyperflexion, hyperextension and rotational injury. But there is absence of fracture, dislocation and intervertebral disc herniation. Okay. Symptoms may start immediately but more commonly delayed. The common symptoms which you may encounter are headache, cognitive impairment and lower back pain. Clinical grading of, hope you understood this. The clinical grading of whiplash injury 0 to 4. What happens in 0 is there are no complaint, no sign. 4 is above fracture and dislocation. One is there is no sign, okay, but there is neck pain or stiffness, tenderness. Then comes reduced range of movement, point tenderness, weakness, sensory deficit, absent deep tender reflex. You have to learn this. Just remember 0 to 4. 0 to 4. 0 is no sign, no symptom. 4 is fracture or dislocation. And 1, 2, 2, 3. No sign in 1, but there will be tenderness or stiffness. In this, there will be reduced range of movement and point tenderness. And 3, there will be sensory deficit, absent tender reflex. Evaluation for grade 1, just to the point to be remembered in this is grade 1. The point to be remembered in is that when there is grade 1, grade 2, grade 3, how do you evaluate? In grade 1, you will do only physical examination, nothing important. In grade 2, you will do X-ray. Grade 3, you will do CT, myelogram, and other MRI. Now the 5 important things to be treatment is range of movement, exercise, encourage activity, cervical collar, passive therapy, medication, surgery. Remember, the surgery is only important in grade 3. We have already read about the grades, okay. The surgery is important in grade 3 and above, not below that. Medication is yes, 3 and 2 plus 3 for medications. Now comes range of motion exercises, which is required in all. Encourage activity, all, but immediately in case of 1 and ASAP in case of 2, 3. Cervical collar, there is no requirement of cervical collar or passive modality in 1, grade 1. But if cervical collar applied in grade 2, it should be not more than 72 hours, not more than 96 hours. But passive modality optional if lasts greater than 2 to 3 weeks, 2 plus 3. The outcome, this is not so important, but there was a study of 117 patients with less than 56 years in Switzerland, and all medical costs were paid by the state. Out of 21 patients, 2 years, 5 were restricted with 3 reduced part-time, 2 on disability. The important point here to be remember is that the patient were maximum if the patient was harmed, it was because the patient was older. Secondly, there were pre-existing disease, but outcome was not influenced by gender, vocation, or psychological factor. 3, 6, 12 months, remember 56, 70, 76 and 82%. Now pediatric spine injury, the very important topic. Pediatric spine injury, age less than 16 years, and spinal cord injury is relatively infrequent. Ligamentum injuries are more common due to flexibility. The 4 type of injuries are AOD, scivora, synchondrosis, and atlantoaxial rotatory fixatory subluxation. In synchondrosis, OS ostidium and C2 synchronous is important. The most important point here to remember is retroclival hematoma. If retroclival hematoma is there is suspicious of AOD. Okay. Now, if AOD is there, the important thing, AOD is there, you will undergo with cervical CT, which will show you CCI. We will discuss further. Most of the stable fractures are treated non-surgically, but C2 chondrosis, here the C2 chondrosis, you give halotraction. Okay. Surgical challenges which can be included are, these are not such important, but the important thing is there is small hardware is required, small size of lateral mass, difficulty removing dismaterial cartilage. Now the very important point here is that the fatality in pediatric and adult, which we will discuss ahead, and I will sort down here so that you never forget it. So the spinal cord injury is very fairly uncommon in children because, and the ratio of head injury is where 30:1 in pediatrics. So the thing which we were discussing above is that in children 30:1 is the head is to spinal injury ratio. Okay, so what happens? Why? Because of ligamental laxity, high body weight ratio, immaturity of spinal muscle, and underdevelopment of uncinate process. So ligament laxity, head to body ratio, immature paraspinal muscle, and underdeveloped uncinate process are the four important things which leads to spinal cord injury, less common in children. Now there comes a physical growth, potential for physical growth, but it has also good potential to heal. There may be tend to causing separation. There is separation of physis in children, but it is less common because it is common, but it has the benefit that there is good potential to heal. The cervical spine is most vulnerable with 42% cervical. To remember, cervical 42%, 31 thoracic, 27% is our lumbar region, CTM. 42%, 31%, 27%. Okay. Now, pediatric cervical spine injury. The pediatric C-spine anatomy in age 67 states that age group less than 9 years, 67% of cervical injury in the upper three segment. What is the upper three segment? OC2. 67% occur in OC2. Now comes synchondrosis. Synchondrosis. What do you understand by synchondrosis? Synchondrosis refers to immobile joint. Immobile. Okay. What happens is there is bone, there is hyaline, there is bone, there is hyaline, and there is bone. This makes the bone immobile. So in these cases, it may be normal thing may be mistaken for fractures, especially the dentocentral synchondrosis of the axis, because they are joined, they look like the fracture has already occurred because it becomes immobile. This may be mistaken for odontoid fracture. Conversely, very important point is that conversely, synchondrosis are biomechanical weak links and actual fracture may occur through thread. Okay, we think that fracture has already occurred and synchondrosis, bone has joined, but they become very weak, and this weakness may lead to fracture. And C2 is the most common vertebral injury in children. Very important point that C2 is the most common injury in the children. Odontoid epiphysiosis, a fracture through the dentocentral synchondrosis. It occurs through the dentocentral synchondrosis. Okay, much of literature says that it is neurocentral synchondrosis, but it is a type of odontoid type of type 2 fractures. Okay, dentocentral synchondrosis, much of the literature states that it is neurocentral synchondrosis, but no, but it is type of odontoid type 2 fracture. 23% will develop neurological deficit. Okay, and 53% of the SCI occur lower level at the cervicothoracic junction. 23% will develop neurological deficit. 53% of the ACL level occur lower to the cervicothoracic junction. Preferred treatment in this condition is emergency reduction followed by external immobilization. Okay, this is preferred. But internal immobilization, fusion should be reserved for patient after 3 to 6 months with persistent instability for internal. This is emergency external reduction with external immobilization, which is preferred immediately. But if there is persistent instability, you will have to wait for 3 to 6 months and you can go for internal immobilization. As we already talked about C2 synchondrosis, and it requires hollow traction with 80 to 90% of success rate. We already discussed here. So with hollow traction, there is 80 to 90% success rate. So already discussed. Very important point, retrocrival hematoma. If retrocrival hematoma is present, if retrocrival hematoma is present, there is what we already discussed, AOD. Now, fracture through C2 dentocentral synchondrosis. Can you see this fracture? The important point here is the anterior angulation. You can see there is the anterior angulation of odontoid. You see this? I'll show you. Process and several of separation from the main C2 vertebra. So I'll show you this, that there is angulation of odontoid. Okay. And several of separation from C2. So this is the image shows. So evaluation in pediatric C-spine. What is the evaluation? How do we evaluate? Now we will undergo with the practical guideline for this, for which level 1 and level 2 will be discussed over here. Okay, so this is the guideline for evaluation. After this, there will be guideline for treatment also. So we will discuss about this. So for level 1 CT, to assess the condyle, as we already discussed here, that we have to undergo cervical CT. You remember cervical CT, CCI in AOD. So why I am going back also, to just correlate and help, it will help you that you doesn't skip anything from your mind. Okay, so level 1 states that CT to assess the CCI, also known as AOI. To remember here is CCI is equal to AOI for pediatric population in AOD. Level 2 for greater than 3, less than 3. The important thing to remember here is what are the differences. Obviously, the patient should be alert, neurologically intact, no hypotension without explanation, non-intoxicated is important. The point to remember here is there will be no cervical tenderness. There is no cervical tenderness or no distracting pain for children greater than 3 years of age. If children are greater than 3 years of age, the different points are GCS greater than 13 without distracting pain. Patient was not in motor vehicle accident or fall greater than 10 feet or non-accidental trauma. These 3 points are important. Other points are not intoxicated, neurologically intact, unexplained hypotension are same as above. So for greater than 3 years of age, there should be no distracting pain, is that totally different. And for less than 3, GCS greater than 13, no distracting pain and not in motor vehicle accident greater than 10 feet and non-trauma non-accidental trauma. Cervical spine X-ray, either you obtain cervical spine X-ray or high resolution cervical spine CT. And for AARF, what is AARF? AARF is atlantoaxial rotation fixation. You should obtain 3 position CT with C1, C2 motion for diagnosis. Okay. One more important is point 2 I will make you remember here is when there is where do we use stir MRI. The stir MRI is used in injury of C2 3 disc and posterior elements. So now two terms, pseudo spread and pseudo subluxation. To remember, I'll just give you one small example. Pseudo spread is lateral aspect of vertebra goes ahead. Subluxation is vertebra body go ahead. Translation. So just to spread is and subluxation. What spread is and what subluxation is. Now spread is mostly seen in C1, C2 and subluxation is seen in C2, C3. Diagnosis, differential diagnosis of pseudo spread is Jefferson fracture. But how will you not show that this is not Jefferson fracture is that it never occur in teenager. Jefferson fracture never occur in teenagers. So you should never misdiagnose. Here the point to remember is that pseudo spread is greater than 2 mm total overlap of the 2 C1 lateral masses on C2. The lateral masses on C1 on C2. On AP open mouth view. Misdiagnosed as Jefferson, I already told you how you will diagnose Jefferson, but it never occurs in. What never occurs in? The Jefferson fracture rarely occur prior to teenage. This is the important point. Why? Because of the lower weight of children. There is more flexible neck and increased plasticity and shock absorbing synchondrosis. So what pseudo spread is? Disproportionate growth of atlas from the axis. It is present in mostly from 3 months to 4 years. Example, the youngest was seen in 3 months and oldest in 5 to 5.75 years. Normal total offset 2 mm during first year, 4 mm during second, 6 mm during third and decreasing after that, but maximum was 8 years. To remember 1 year 2 mm, 2 year 4 mm, 3 year 6 mm, but after that there will be decreasing, but maximum was 8 mm normal total offset. Very highly important point here is that trauma is never a factor seen in pseudo spread of atlas. Okay, so trauma is never seen in pseudo spread. Another way to find out that it is not a Jefferson fracture is you can go for, when you are suspicious, you can go for thin cut scan parallel to through C1 can resolve issue of whether it is fracture or not. Okay, thin cut CT scan parallel to and through C1 you will take to see whether Jefferson is there or not, to see fracture is there or not. In case you are doubtful with Jefferson fracture, so I have made myself clear in this topic Jefferson. Hope you guys came to know about it. Here only one thing is to remember and to point out is Jefferson fracture. How will you differentiate is that it never occurs in teenage, and if you are in doubt you can go for thin cut CT scan parallel to and through the C1. Now what subluxation is? Pseudo subluxation. We already read about pseudo spread. What subluxation is, we will talk about it. That there is anterior displacement of significant angulation of C2 on C3, as already I have shown there. Occasionally there will be C3 and C4 also. Okay, on lateral spine CT or sagittal X-ray at sagittal CT or MRI, which may normally occur in up to 10 years. It can normally occur in age up to 10 years. Occasionally in C3, C4. Okay. So, this is pseudo subluxation, which is normally seen up to age of 10 years, less than 10 years. So you can see C2 over C3 in this image. So what is the physiology behind this fracture of subluxation? We are talking about subluxation. We have already talked about the pseudo spread, but now we are talking about subluxation. What is subluxation? In subluxation, what happens? Flexion, extension, what is there, which are initially centered at C2, C3, but it gradually moves down. Okay, the flexion extension is seen initially at C2, 3, then it moves down. By the age of 10 years, we have already talked about it, 10 years, less than 10 years, always less than 10 years in most cases. Okay, so C2, okay, a very important point is C2 normally moves forward on C3 up to 2 mm Paediatric. So this is normal, but it can be exacerbated by paraspinal spasm at lower levels, but it does not represent pathological instability. Very important concept, that C2 normally moves C3 on 2 to 3 mm in pediatrics, and forward displacement on neck flexion can be exacerbated by paraspinal muscle at lower level, but it does not indicate that there is pathological instability. Okay, so what is true subluxation? When we call it a true subluxation, it occurs in two conditions, where there is fracture, injury is to C2, C3 and posterior ligaments. Okay, so what happens is C2 vertebra move forward without a corresponding displacement of the posterior element of C2. Okay, C2 moves forward without any corresponding displacement of posterior element of C2, but only anterior. Okay, there are two situations, either it is suspected or it is presumed, presumed present or assumed present. Only two things are seen, either it is suspected or it is present. In suspicion, what happens is a base, if the posterior cervical line from base of spinous process, if the posterior line is above 1.5 mm posterior base of spinous from base of spinous process, the posterior cervical line is 1.5 mm, it is suspected. If it is greater than or equal to 2 mm posterior, then it is presumed. Another name of posterior central line is Schwischuk.